ICD trainer of Grassi Healthcare Advisors. Before we begin today, I would like to let everyone know you will be receiving a recording of today's webinar and Joe and Alicia's contact information for any further questions you may have. Throughout the webinar, questions can be submitted on the bottom right-hand corner of your screen. If you're also having any technical difficulties, please feel free to submit those at the bottom right-hand corner of your screen. Without further ado, Joe, please take it away.
Great. And welcome everyone, and thanks for logging in. We're only a few weeks away from the beginning of PDPM, which I know you've all been anxiously awaiting and working hard to prepare for. What we're talking to you about today is one component of PDPM preparation, and that is dealing with the ICD-10 coding. For years, we have included ICD-9 and then ICD-10 coding as part of the MDS assessment, but it really didn't impact reimbursement. It was more for the research purposes of the people who are working on the payment methodology. And of course, now we're seeing the results of that. And as we talk about PDPM, and I'm going to give a brief overview. I know many of you have been through many trainings, but I'm going to give it to you just one more time briefly to lay the context for what we're talking about today. And also, the adult learner needs to hear things 7 times before it sinks in. So every time you hear it, you're going to get a little different piece that you might not have gotten previously. All right, so the objectives today, we're going to go over ICD-10. We're going to talk about how ICD-10 coding is utilized under PDPM. And we're going to understand how the clinical category mapping tool is utilized and understanding which components of the PDPM the diagnostic code is used. So this new system that's coming about October 1st is a recategorization of patients for Part A Medicare states. It doesn't affect managed care unless your managed care contract includes PDPM specifically, and I doubt at this point it does, although some of the plans may migrate to that. But it only covers right now traditional Medicare Part A. If your state uses the MDS for their case mix classification for Medicaid patients, it may also impact that. In New York State, for instance, they're not transitioning to that for another 2 years. So Reg 4 is going to continue to be the categorization for case mix that's used in New York State. What the major difference right now is that PDPM separates the amount of therapy from payment. It no longer relies on the minutes of therapy provided to a resident to drive the reimbursement. So back, in the late 90s when PPS first came about, I was director of nursing at the time. I remember the joke was that we were all going to put rehab out in the parking lot in tents so they could start therapy as soon as the patient arrived on the property. And it's only half joking. You may recall back then that we only did therapy 5 days a week. Suddenly now it became important to do therapy 7 days a week because you wanted to make sure then in this first couple of days you got therapy started, because that initial MDS was going to drive what category the patient was in. That's no longer necessary. Now there's going to be 5 different components, each with its own discrete case mix adjustment that classifies the patient into a category, and one category doesn't drive the reimbursement the way it did under Reg 4. It incorporates a variable per diem payment adjustment for the PT, OT, and non-therapy ancillary components, which results in decreasing daily payment as the resident's stay progresses. So for the first couple of days, the reimbursement is higher, and then it drops, and then it drops again at day 20, and progresses down. And the rationale there is that they're thinking is that people improve as time goes on, and they don't need the same intensity of services. It also reduces the number of PPS assessments. We only need to do the 3-day assessment, which can be done anywhere from day 1 to day 7, I believe, and a discharge assessment. And then there's a new interim payment assessment that can be, probably the best way of describing that is the old significant change assessment. But that's basically if someone has a change in status that you believe is going to change how the reimbursement is for that patient, you can complete that. So this slide shows the major difference. In the left, under RUG 4, the categorization was based on predicted services, based on what was provided in those first, basically the first week of patient stay. Under PDPM, we go to a categorization of the patient based on their diagnosis, their MDS, their functional status, and their cognition. And they come up with what the average price is to care for someone with those characteristics that will reimburse for their care. As I said before, PDPM removes the therapy minutes as a determinant of payment. Patients still need therapy, and they're still expected to get therapy. It's just that it's not what's driving the reimbursement. As I said before, the payment classification utilizes a combination of 6 payment components. There were the 5 I talked about before, and then there's one that's basically like the room and board at the standard non-case mix adjusted level. Here, this slide shows the different clinical categories: nursing, PT, OT, speech, and non-therapy ancillaries. As you can see, nursing has 25 different levels that are based on the clinical categories and functional levels from the MDS section GG. The physical therapy has 16 based on function, cognition, and clinical category. Occupational therapy, same thing. And speech-language pathology, same thing. The non-therapy ancillaries are based on specific diagnoses under extensive services, which Alicia's going to speak to in the second part here. Payment for each component is calculated by multiplying the case mix index that corresponds to the patient's CMG by the wage-adjusted component-based payment rate, and then the specific day in the variable per diem adjustment schedule when applicable. As I said, it decreases from the beginning of this day towards the end. The rate is the sum of these 6 components subject to 2 additional adjustments. The PDPM model incorporates an adjustment to the PTOT and non-therapy ancillary to reflect CMS findings that costs for these 2 components are higher at the beginning of a Part A stay and decrease. Longer stays dilute the impact of this adjustment beginning after day 20. Here's an example of how you have the 6 categories that all add up to what the total rate is for the patient. So you have the nursing case mix, the non-therapy, the PT case mix, OT, speech, and case mix, the standard one for room and board. So what you do is you go across and add those. Now you remember in RUG 4, you found the category that had the highest level of case mix, and that became the payment category for the resident, and all the other categories no longer mattered. Under PDPM, you can see it's an additive effect of each component. So it shows the importance of each and every component to the assessment and to reimbursement for the patient. To determine how the client's characteristics relate to payment, residents who would be categorized, say, for rehab payment are based on 3 resident characteristics within the MDS admission. One is the clinical reason for the resident's stay, and this is, again, the focus of today's discussion. In item I-8000 on the MDS 3.0, this is where the ICD-10 code representing the diagnosis for which the patient is receiving the most amount of care in the facility is placed. And again, I want to reiterate that. This is where that ICD-10 code that represents the reason where the most significant resources are being applied for that patient's stay are indicated. And this, again, is what Alicia is going to speak to you about. The resident's functional status, of course, comes from the MDS, that's section GG, and the cognitive status from section D of the MDS. The clinical reason for the stay for OT, PT, and speech is used to categorize the patients into 5 clinical categories that have been identified as being generally predictive of PT and OT costs. These are major joint replacement or spinal surgery, other orthopedic, non-orthopedic surgery, acute neurologic, and medical management. So depending on what ICD-10 code is used for that principal diagnosis, if the patient needs rehab, it's going to fall into one of these 5 categories. Now, why is that significant? Of course, you know that if someone has, say, major joint replacement, there's very heavy rehab needs from a time perspective and a resource perspective, and that's going to be weighted more. If someone's in for medical management, say after they receive chemotherapy and their rehab needs more relate to debility and the need for strengthening, the resource needs are not as great. So you see why that diagnosis of the principal reason the patient is in the hospital, is in the nursing home, will drive what category for rehab reimbursement they go into. The functional score for PT and OT, of course, comes from section GG, and you're familiar with that. Under PDPM, just under rug 4, patient's cognitive status is calculated under section D. We have a separate webinar on completing section D properly, and that's actually tomorrow going to be available on our website for free download if you're interested in that. Okay, Alicia, why don't I turn it over to you now and talk about ICD-10 coding specifically and how it relates to PDPM, and I'll pipe in as needed.
Sure, yeah, great, thanks, I appreciate that. So yeah, I mean, I would want to give you an overview today of ICD-10 in general, as well as how does it fit into PDPM, and you'll be utilizing it in your daily workflow and in your daily lives here. So the ICD-10 was developed through the World Health Organization, and as we know, it replaced the outdated ICD-9 CM conventions. And under ICD-9, there were really only about 13,000 codes, and we've gone from those 13,000 to almost 70,000 codes. And as we go through this today, we're going to understand why we have so many more codes, because we've added things to the category like etiology and site and severity. So we're gonna see how the codes break down, and then the more you use them, the better you'll understand how they work. ICD is adopted by countries all over the globe. Basically, it's been utilized to gather information and statistics on disease, as well as, we use it for payment purposes. And ICD 11 has been completed, the beta testing for that, although, we always seem to be behind on adoption. So keep your eyes out peeled for that. Once we get ICD 10 down, well, I'm sure we'll be switching like everything else. So as Joe mentioned, the ICD-10 codes were not utilized under the RUGs as a direct impact on reimbursement. Primarily, the diagnosis code sections were basically checkoffs. But under PDPM, there is a direct relationship between the code assignment and the payment categories, as Joe was mentioning. Next slide, sorry. Thank you. So just to give you a little structure of how the ICD codes are composed, back under ICD-9, there were 5 digits. Now the codes have 3 to 7 characters in length. Again, there's approximately 70,000 codes available to choose from. We're going to talk about the importance of the level of specificity. If you notice, the characters 1 through 3 of the codes are numeric and alphanumeric. The first is usually an alpha, and the second are numeric. The codes actually have some place markers in them, X place markers, and we'll talk about that. So it's giving the room for expansion. Again, they're very specific. They have laterality built into them. If you notice, the categories, the first 3 codes basically represent the category, and then the characters 4 through 6 of the codes really describe the etiology, the anatomic site, the severity, the laterality, or some other clinical detail. And then we're going to talk a lot about the 7th character extension when we get to that part. That's going to be very important when we talk about fracture codes and episodes of injury. Next slide, please. Thanks. So just a couple things in general about diagnosis coding. We always want to code to the highest level of characters available. Even though some of the codes are represented at their highest level only using the 3 category characters, you're going to see many of the codes that you'll be using will actually break out to the full 7 characters, right? Like we're going to see example of ICD-10, which is hypertension, which is I-10. And those 3 characters do represent a valid code. But as we go through and we look at how in-depth and detailed the codes we need to be, you'll see that you'll really be building them out to the 7th character. Next slide, please. So we want to help you kind of lay out your roadmap for ICD-10 success. And again, while you don't need to be, certified coders, you really should have some individuals in the organization who are clinical ICD-10 champions, who really understand how to code, how the codes, link into the components under PDPM, under the clinical components. So the first thing we really recommend, it's kind of what you're doing today, introductory to the ICD-10, having that in service. Also a diagnosis intensity focus. Go back and look at the diagnoses that are most frequently used in your organization and make sure that the documentation is supported and that they are listed to the highest level of specificity. Make sure you understand how to use the crosswalks. Really, we've been working with some of our clients doing some documentation readiness assessments, which we were finding has been a really critical exercise for them. We're going to talk about some of the most important components moving into the PDPM model is that the diagnosis has to come from the provider. So we've been finding some deficiencies there where some people that we're working with, really it's been very productive and helpful exercise. Gives you time to kind of get to the root cause and then put corrective action in place before this goes live in a few weeks. The last thing you want is this to really impact your bottom line. Again, pulling out some advice. Yeah, sure.
Let me just punctuate that a little bit, having run nursing homes. So what this means, what Alicia just said, the ICD-10 code has to come from the provider. What typically happens in nursing homes is say the MDS nurse will, maybe who's doing the person doing the coding, will look at the medications that are ordered and the diagnoses associated with those medications, look at diagnostic tests that have been done, looked at the transfer forms from the hospital where the nurse from the hospital writes what's going on with the patient, and might, from all that documentation, come up with what they think the ICD-10 code should be. But that would all be unsupported in a review of your coding. It has to be that the medical provider, a physician or nurse practitioner, makes an assessment of the patient, either on an initial assessment or a visit, and makes a determination based on their assessment of what the diagnosis is. And that then is drawn from the medical documentation. I can't emphasize enough that, and as Alicia and I have done workshops with facilities and we look at where they came up with the coding, what documentation supports it, it's usually not there. It's got to be in, and you've got to get your providers on board. And then you add on the additional component, what I said earlier, that it needs to be the diagnosis that drives the most resource utilization. You got to make sure you really have good communication with your providers, that you're on the same page about what is the most resource consumptive in your mind and what it is in their mind. I'm sorry, Alicia.
No, yeah, please, my pleasure. Actually, we're going to get to some of that as well. I think it's also important to realize that, and I'm sure you're already realizing this in your preparations, that there's going to be a need for some workflow changes. As Joe mentioned, a lot of times the information is gathered from different sources. It really has to come from the provider documentation. We talked about the ICD-10 champions. Again, you don't have to be certified coders, but it is critical, I think, to have individuals in the organization who understand the coding and can help select the best codes to represent the services that you're going to be billing for. And then after you have everything in place, it's important to go back and do some post-implementation reviews and follow-up, right? Not always, sometimes when we implement things, we tend to find out after review that maybe they need some tweaking or some changes, and they're not always working as we thought they would. Next slide, please. So what are some general coding guidelines? In general, it's really important to make sure that the diagnosis codes are always listed at the highest number of characters available, up to the 7th character if they have it. And you'll see codes that are selected and sometimes supported that don't have all the characters that are necessary are actually considered to be invalid codes, right? So we're going to see when we get to the clinical mapping tool later where some of the diagnosis I think that the nursing facilities are used to using are actually going to get kicked back to the provider for more detailed information. So unspecified codes, they're not going to work. They're going to be invalid, and you're going to be getting rejections on that. So we want to make sure coming out of the gate that everything is listed to has the highest level of specificity as possible. Again, you know, you can code signs and symptoms. I don't think that's really applicable in the skilled nursing facility setting. And then don't add codes of signs and symptoms when you already have a definitive diagnosis or disease process. So for instance, if the patient is diagnosed with pneumonia, you wouldn't want to add codes like cough. Again, in reporting now under PDPM, some of the area and space that you're going to have is going to be limited. So you really want to capture the most resource-intensive diagnoses first. And then multiple codes may be needed to fully describe the patient condition. Under ICD-9, we didn't really have combination codes, but under ICD-10, there are a lot of combination codes, and we'll look at some of those. Next slide, please, Lauren. Great. Here's, let's see. So this is an example if the patient has what's considered both an acute and chronic condition. Again, the acute condition gets sequenced first, and then the chronic condition second. Next slide. Just keeping in mind, sometimes patients might have both. So now this is important. This is going to be very important, actually, for everyone to understand. So the addition of the 7th character under ICD-10 is used in some chapters, in pregnancy, which I don't think is going to be applicable to you, but also chapters 19 and 20. And it really provides more information about the characteristics of the encounter. So under the intrusion and external causes, the 7th character of A represents an initial encounter, D represents a subsequent encounter, and then S as a 7th character is sequela. However, as we know it, initial and subsequent is not how the definition of this is represented. Next slide. Now, under the 7th character extension A, under the initial encounter means that the patient has an acute or active conditions. It doesn't mean necessarily it's the first time we're seeing the patient. Usually we think of initial as the first time and subsequent as every time thereafter. However, important to understand getting that 7th character correct here. A, again, acute or active conditions, emergency encounter, evaluation and treatment by a new physician. So maybe the patient is undergoing treatment for a condition, and a new provider comes in to see the patient that day for that. So it's the first time that that provider is evaluating and treating the patient for that condition. So his code the 7th character would be an A that day. And then subsequent encounter, the D, 7th character D, is really when the patient moves into the healing or recovery phase. If they have a cash change or removal of external or internal fixation device, a medication adjustment, or other aftercare and follow-up visits following the initial treatment of the injury or condition. Next slide. The 7th character of S is for a sequela encounter. This, complications or conditions that arise as a direct result of a condition. Usually when you are representing the patient has a sequela, usually 2 codes are needed here. One for the condition, and then the second code represents the sequela. An example of that would be a scar from a burn per se. Next slide. So under the fractures, there are additional 7th characters that are used when you are reporting fractures, and they give more information from, this is an initial counter for a closed fracture, or, maybe a routine subsequent visit for a closed fracture with routine healing. And you can see there's different types of fractures here, whether it's delayed healing or non-union. So again, when you have diagnosis codes of specific fractures, these are the 7th characters that are necessary on fractures. Next slide. Again, we talked about under ICD-10 having these additional X characters. They're really for expansion. So sometimes the code may need a 7th character, but the code in totality doesn't actually have up to 6 characters. So sometimes you'll see an X or 2 X's in there, and basically they are placeholders. And again, that's just for future expansion purposes. You can see that there's an example on the bottom here, foreign body of conjunctival sac left eye sequela. This only was a 5-character code, but it needed the S on the end for sequela, so there's an X placed in there as a placeholder. And again, initial encounter for contusion of the buttocks, there's 2 placeholders in that code. So that's going to be a common thing you'll see in the codes. Next slide. So combination codes. You shouldn't use single codes if there are combination codes. So single code is used to classify 2 diagnosis codes or a diagnosis with an associated secondary process or manifestation. Multiple codes should not be used when there is a combination code, and basically it allows you to submit fewer codes with more clinical information. Next slide, we'll see some examples of those.
Alicia, would you say this is a good reason why people should make sure they use their books and not cheat sheets to code?
Yeah, we're going to talk about that as well, definitely. And it's not always important to use the books, but make sure they're of the current year. I know sometimes, not just organizations, but practices tend not to get the new books every year, but there are changes. And since we've been moved into ICD-10, there's been a lot of changes. So the book really helps you kind of break down and understand, the breakdown of this. There's also, a great online tool called ICD10data.com. I use it myself. It also helps you to see the full breakdown of the codes. One of the things, we talk about so much is the documentation and how important the documentation is to support everything that you're doing, everything that you're billing for. If you're ever audited, you want to make sure that your documentation is there to support the things that you're billing for. We see so many practices and organizations end up in trouble there because the documentation really just doesn't stand up when you're submitting those codes and you're asking for reimbursement. And we are pretty confident that, there's going to be some grace period in the beginning, but at some point we're going to start seeing audits rolling out on this to make sure that you guys are getting this right. Just for example, some of the documentation details that need to be in the patient's medical record when the provider is diagnosing a patient with diabetes. The doctor has to give you enough information to make a specific diagnosis, right? You need to know what type of diabetes. Is it type 1 or type 2? Is it due to any underlying conditions? Are there any body systems affected? Are there complications or manifestations? Was it drug or chemical induced? Is the patient on insulin? There has to be a documentation of the use of insulin. And actually there's additional codes when patients are taking insulin that you would be required to use. And I don't think gestational diabetes here is going to be applicable to you. Next slide. Again, the episodes of care, we talked about making sure the documentation has the detail, right? Is this the initial encounter? Is it a subsequent encounter? Is the patient acute going, or are they in the healing phase? Or, are they being seen for late effects of an injury? And then the fracture and wounds, making sure that you're documenting whether they're open and closed. And then they're, again, very site specific. We're going to look at some examples where the documentation says, unspecified. And those codes now, they're not going to get through. So next slide, please. Again, site of dominance for cerebral infarction. You have to make sure that the documentation supports whether it's right or left, or site of dominance, whether the patient's right or left-handed or ambidextrous. Under acute myocardial infarction, there are specific documentation requirements, how many days. And again, this is just based on from ICD-9 to ICD-10. Some of the age definition for AMI has changed from 4 weeks to 4 weeks from 8 weeks. That's probably not really applicable. Next slide. Again, in details in the documentation, and we're driving this home because we can't stress enough the importance of getting all the proper information as detailed as possible into the documentation so that the diagnoses are going to be supported. So again, just anatomic specificity is required for fingers, toes, hands, foot, eyelids. The codes are very specific now to which side, laterality. And again, you're going to see some codes that say, we'll see some examples of it. It doesn't say left or right, it just is unspecified. And that's not, there's no way that the doctor doesn't know which side that the patient has an injury on. Next slide. These are some external cause of injury codes. They're not mandatory. They are very helpful. Basically so this is if there's any type of injury by an animal or a car or a bus, they want you to document that. And again, there's a huge section in the ICD-10 book, very, very specific details around a collision or the location of the patient or an accident, whether it was traffic or non-traffic, activities at the time of injury. Falls may be very applicable for you. Did they fall from a height? What were they doing? Did they hit any objects? I know sometimes coding around falls has been difficult. Again, making sure, usually we do get a lot of questions around diagnosis coding for falls. And really, what was the reason for the fall in addition to the fall codes that you'll be using, right? Did the patient have vertigo? Were they unsteady? All those things are important to make sure that you're capturing. And then any injuries by object. Next slide. Again, injury, poisoning, and other causes continued. Were there, did the patient overdose on their medication, or did they have an injury due to underdosing of their prescribed medication? Was it intentional? And what were the reasons why the patient didn't get their medications correctly? And then there's some very specific documentation detail guidelines around patients in coma. The 7 digits that's required for the Glasgow Coma Scale based on their score. And then here, and again, the ICD-10 book spells this all out for you, and it'll also give you additional information if you need to look elsewhere in the book to gather more information. Next slide. Again, just some general coding guidelines, right? The level of detail, the diagnosis code should always be reported at the highest level. Next slide. We're going to talk a little bit about the first listed principal diagnoses as well as the primary diagnosis a little more in detail. Again, the first listed principal diagnosis defines the reason for the patient's encounter or admission. And we know that in the past, sometimes the diagnosis has been rolled over from their reason from the hospital, but your principal in your organization, your first listed principal diagnosis is going to be the reason why the patient is coming into your nursing facility. And that diagnosis should represent the condition that's going to require the most resources. Next slide. Signs and symptoms, again, we talked about this. If there is no definitive diagnosis, certainly it's appropriate and applicable to code for signs and symptoms, but as soon as the patient has a definitive diagnosis, those signs and symptoms diagnosis should be replaced with that diagnosis. Next slide. Acute and chronic conditions we talked about. Again, if the patient has both, coding acute first. Next slide. Sequela, we talked and think enough about this. Again, generally 2 codes are required. The condition is listed first and the sequela is listed second. Again, there's no time restriction on these injuries or coding for these conditions. Next slide. Resolved conditions. Again, we're going to talk a little more about this in detail. Really important to make sure that your diagnosis code lists are cleaned up, right? The diagnoses that are listed have to be active. Really important to make sure that you're getting, now's a good time to go through those diagnosis lists of what's active and what should be, marked as resolved. Because again, you're only going to be dealing with active diagnoses here. Next slide. Abnormal tests. Again, abnormal tests, coding for abnormalities from unless there's a clinical significance, should not be used as a diagnosis code. Next slide. BMI and pressure ulcers. I know one of the questions we've gotten in the past about BMI, can the BMI be used to list a diagnosis of obesity? And the answer to that is no, because the diagnosis of obesity has to come from the provider. The clinical assessment, even if the BMI may represent a patient who's obese, to give the patient a diagnosis, it must be documented in the record by the provider that the patient has obesity or morbid obesity. And then pressure ulcers, again, be aware there are combination codes, and they include laterality, and they include specific anatomic location, and then making sure that you're assigning the appropriate stage. And then if a patient has pressure ulcers with multiple stages, the highest stage for the evolving ulcers is always listed first. Next slide. I don't think this is applicable. Borderline diagnoses, we don't ever really, the provider may document that they think the patient may have a condition, but we don't ever give them a diagnosis of that until it's confirmed, right? And the next slide, pending threatening diagnosis, again, it's not really applicable for your setting. Again, if the condition occurs, report only if they're confirmed as diagnoses. Next slide. Okay, so now we get to the meat and potatoes, right? Some factors which are going to impact ICD-10 code assignment. Again, Joe mentioned that information provided comes from many different places. You may have discharge summaries, you may have, nursing notes, you're going to have paperwork coming from the hospital. The only diagnoses that you can use is what you can gather from documentation from the provider, which can be a physician, a nurse practitioner, or a physician assistant. Lack of specificity from the provider, hip fracture, pneumonia, stroke, DM for diabetes. We saw what the documentation needs to look like. If they're having a diagnosis of diabetes, you need a lot more information than just diabetes. And then lack of clarity regarding what is the principal or primary diagnoses, right? So these are some factors that are going to impact your code assignment. And then the culture of therapy seen as the driving force for skilled care. Next slide. So we talk about, how important it is that every facility should have a policy and procedure on the diagnosis code assignment. Some of the items to be addressed in your policy, certainly it's not limited to this, following the coding guidelines, what diagnoses are to be used, and frankly, what diagnosis should not be used. Time frame for coding, when it has to be captured, when the providers have to see the patients, where the information should come from, documentation sources for the diagnosis, and then querying of the provider. How are you going to handle that? If you have information that's not complete and you cannot get a diagnosis, valid diagnosis, or a diagnosis is the highest level of specificity, how are you then going to query the provider for more information? And again, when you put your policy in place, you need to go back and make sure it's actually working for you.
You know, Alicia, that also points to the importance of having the medical provider do a initial assessment pretty early on in the admission. If you're doing that MDS, that first MDS at day 3, day 5, up to day 7, you need to have the medical provider documentation in the chart that you can draw from, right?
Right, exactly. Next slide. So yeah, I mean, so this was what Joe was speaking about in the beginning here, where so the coding diagnosis in section I is not based on the ICD codes, right? There's still that check off for Alzheimer's, Parkinson's, and then the basics of coding a diagnosis include the disease conditions, which are going to be in section I. Again, this is just reiterating that it's required to be by the provider. Next slide. Again, any diagnoses that are communicated verbally have to actually be documented in the medical record, and also, you know, by the doctor, but also to ensure that they're followed up on. Any past histories obtained from family members or close contacts, make sure that those are getting into the documentation by the provider. Once a diagnosis is identified, it has to be determined if it's active, right? So Joe, this goes back to what you were saying about the look back period, that the providers need to be getting in to see the patients timely, and then capturing the information in the record that's going to be help to determine what those diagnoses are. And again, going through the list, getting rid of all the old diagnoses in the patient's charts that have then since been resolved is going to help to make sure that you're capturing diagnoses that are truly active for the patient's conditions. And then again, we're talking about whether they're resolved, then they should be archived, put in the resolved list. Next slide, please. Some coding rules which directly impact skilled nursing facilities. Again, the diagnosis has to be captured by the provider. Like, we just keep driving this home, I think, you know, because so much in the past, you know, we've been able to gather that information from some of the nursing notes. And we just know that when the audits start rolling out on this, it's going to be critical to make sure that you're able to show where the diagnosis information is coming from. Again, this goes back, Joe, to you and Nadine, how frequently when the patient should be seen. Long-term residents who return after a hospital admission, they must be coded as the reason to why they're long-term, right? That's important. Next slide. The use of the 7 characters, again, this is going to be really important. A for initial, the D for the subsequent episodes. And then, again, making sure you're using your book and you have your internal clinical champions. This is just a tidbit of information here that the stroke-related codes are not I-69, are I-69, not I-63. Next slide. Some implications of the clinical category mapping. Most rehab codes are not going to be accepted as primary. We're going to see some of that where they say return to provider because they're going to be lacking specificity. Again, those are all going to have to go back to the provider. So we're going to need to make sure you guys have your policies in place of how are you going to get that information. Secondary diagnoses are going to impact the final payment through the non-therapy ancillary points. So making sure that other conditions that the patients are being treated for are also listed there. The ICD-10 code must appear in the I-8000. This is just reiterating what Joe spoke to earlier. Next slide. So here's what some of the diagnosis codes that look like that are going to be in that return to category when they're listed as primary. And I know in some of the clients, the workshops that we've been doing, you know, we get some, you know, not giggles, but some, you know, little bit of, because laughing, because these are the codes that you're actually seeing. Like, they see these codes all the time, but these are codes that are going to be kicked back to the provider. Hold on. Sorry, 1 second. I'm having a little technical difficulty. Okay. So muscle weakness, personal history of pneumonia, encounter for other specified aftercare, or weakness in general. If you see there, what is the code? Non-displaced transverse fracture of shaft of unspecified fibula, routine healing, right? So they have the D there, the 7 characters appropriate, but because they listed it as an unspecified fibula, that is an invalid code. Next slide. Again, just some additional codes: age-related debility, altered mental status, repeated falls, unspecified lack of coordination. Next slide. Malaise, that's a big one, right? Fatigue and malaise. Unspecified abnormalities of gait, dysphagia, all phases. Again, making sure that there's enough information to code to the highest level on these so they don't get kicked back, returned to provider. Next slide. So these are some diagnosis codes which are medical management or acute neurologic when primary. Other abnormalities of gait and mobility, ataxia, ataxic gait. Next slide. Other symptoms and signs involving the musculoskeletal system, neurological neglect syndrome. Joe, I don't know, do you want to talk a little bit about the difference of the categories where they fall under the acute neurologic or?
Yeah, so what they're saying here that, if you're using something like other symptoms and signs involving the musculoskeletal system, because the biggest need of the patient is physical therapy, it's not going to work well for you, because that's going to be categorized under a medical management, one of the nursing categories. What you'd want to look for there, if you really thought there was a lot of rehab needs during that stay, would be what the principal neuromuscular diagnosis is. For instance, multiple sclerosis, or some other neurologic symptom that more specifically identifies what that category is.
Right, thank you. Next slide. And again, just more examples of the same. Next slide. So 5 mistakes often made selecting ICD-10 codes in the skilled nursing facility, which we've seen. Again, using the unspecified codes because they never really impacted payments, so it wasn't as as important. Of course, it's important, but it's not as important as it is now, because now it's directly going to have an impact on the payment. Coding for resolved diagnoses. Again, we're talking about that. The diagnoses have to be active, and the documentation has to represent that. Incorrect 7th character, using those incorrectly. So hopefully today everyone understands the difference between initial, subsequent, and sequela. And then again, your ICD-10 book will be a great resource if you do need to add additional 7th character information on fractures. Coding from the internet or a cheat sheet or the facility software, and we talked about that. Joe mentioned that, how important it is to make sure that you have a book, make sure it's the current year. Not Googling for codes. Again, we talked about that great resource online, ICD10data.com. That's a terrific site that we use ourselves for ICD-10 coding information. And then coding a diagnosis that was not documented by a provider. I think that's going to be a big one. And I think that should be on the top of the list, making sure that you're going to be able to back that up when you get audited, that the diagnosis came from the documentation from a provider. Next slide. Again, we talked about, just some other mistakes, using single codes when there are combination codes, especially for some things like chronic kidney disease and heart failure, diabetes with manifestations. I can foresee probably a majority of the patients that required skilled nursing facility stays are going to have you're going to see opportunities to be using some of these combination codes. I would make yourselves familiar with them. Again, using the hospital-based diagnosis without having a current provider reviewing it. Using an aftercare code when not appropriate, right? Aftercare of surgery, not injury, and encounter for other specified hospital aftercare, right? You have to have your own principal primary diagnosis of why the patient is being admitted to the facility. Next slide. These are just some examples of the combination codes for hypertension. Again, we talked about the 3-digit category, hypertension, I-10, but you can see hypertension with heart disease. They want to know whether it was with heart failure or without heart failure, hypertensive with chronic kidney disease, the 3 categories, I-12, but you need to provide more information with stage 1 through 4 chronic kidney disease, with stage 5 chronic kidney disease, or end-stage renal disease. And then hypertensive heart disease with chronic kidney failure, chronic kidney disease. So you can see how the codes progress down. And again, just being aware of these codes, which ones do have combination codes, will be helpful. And then your book is going to help you drive down to the level of information that you're going to need. Next slide. Some common diagnoses which need additional information, MCA or CVA, were there any residuals, what were they, if any? Again, MCA or CVA with hemiplegia, the left side, the right side, was it a dominant, was it the non-dominant side? So you can see how the level of specificity really needs to be driven down to the documentation. And we can't stress the importance enough of education and training for the providers. And hopefully a lot of the providers that are, working in the facilities are working other places in the hospital where this has been required for quite some time. So hopefully there's not going to be a huge learning curve. But I think it's really going to be important to make sure that they're educated and understand the level of documentation that they're going to need to get in the medical record for you to be able to back up those diagnoses. Again, pneumonia, what's the cause, what type? And again, we talked about the diabetes. Next slide. The principal diagnosis is defined as that condition established after study to be chiefly responsible for the admission of the patient. And we've talked about that through the presentation. Next slide. Comorbidities or additional conditions that coexist at the time of admission, they should also be listed. Next slide. Again, just going back to primary and principal diagnoses, the primary diagnosis is the diagnosis that's going to drive the need for the most resources. Next slide. This is just reiterating again, active and then documented by the provider. Next slide. We talked about this also, both Joe and I, through the presentation, different sources of information, hospital information, transfer information, history and physical, progress notes, consult notes, surgical reports, and then diagnostic information from labs and x-rays, it's certainly helpful, but again, it cannot be used as the source of the diagnosis. Next slide. So just a little bit about the clinical category mapping tool. That's an Excel spreadsheet. It's available online. Make sure you're using the most current and up-to-date tool. Again, searching for things in the tool. This is just saying no decimal points. Just start typing in and those will appear.
I'm sorry, you're talking about the one that CMS has developed. It's on the CMS PDPM webpage, right?
Yeah.
Yeah.
Yep. Next slide. Okay, getting ready. We've been getting ready. You've all been getting ready. So what are the things that we think are the most important provider-related things, educating the doctors, right? Get them up to speed on the new system, what you're going to need to be able to capture accurate and complete diagnoses, making sure that you're getting that information within the time frame that you should be. Establish a procedure for querying the doctors. We talked about that, getting that into your policy, making sure everyone's on the same page. Everyone knows what they should be doing and where they should be going when they have questions. And then again, making sure that the providers are seeing the residents in a timely a manner for capturing the needed information. Next slide. Attending education as necessary. Again, today, this is a high-level overview giving you information on the ICD-10 in general. And again, your books are going to be a critical guide for you. The answer's in the book. That's what we always say, like, get it from the doctor and you can find the codes in the book. Making sure that you're adhering to the guidelines, reviewing the current procedure, make sure that all of this is being done timely, again, assigning the accurate codes, and then, again, just developing that policy. Next page, next slide. Going back again, just making sure that you're reviewing that the codes are current, cleaning up your list, making sure that you're determining what the actual primary diagnosis is, doing that as a team, making sure you have good internal communications. I mean, that's really going to be critical, I think. And Joe, you can speak to this. Getting the primary diagnosis right, making sure that you're listing that code that's going to require the most resources, I think is going to have a huge impact on payment under PDPM.
Yep.
Ensure that the entire team is educated, implementing the review process, such as triple check, making sure that once you have all your processes in place, that you're going back and actually auditing and testing them to make sure that they're working. Consider implementing a clinical documentation integrity process, having someone go through and do your own internal audits. I think it's going to be a critical component to survival when after, the learning curve is kind of simmered down and the audits for this start ramping up. I think doing that internally is going to have a huge impact on mitigating your risk of overpayment recovery demands. And then again, making sure that there's backup in the note for the diagnosis that you're assigning. Next slide. Again, Joe mentioned this in the beginning. Consider incorporating the diagnosis review along with the admission drug regime review, evaluating the setting of the assessment reference date, the ADR, due to the availability of the diagnostic information.
Let me add to that. I just want to reiterate. Remember the day 5 assessment. We said the assessment reference date can be anywhere from day 1 to day 8. But remember, you have a 7-day look-back period. Now, if your physician doesn't get in until day 3 and give you documentation, or day 5, let's say, to give you documentation, then you're stuck using either day 4 or day 6 as the assessment reference date. If you want to be able to use the 7-day look-back to go into the hospital period, you're going to lose that opportunity the later the physician or nurse practitioner is in giving you that diagnostic information. The worst case would be that they get in on day 7 and you do your ARD on day 8 and you lose any look back into the hospital period for any of your MDS items. So it's really important that your MDS scheduler, coordinator coordinates with the medical providers and has good cooperation there. I'm sorry, Alicia.
No, please, helpful. Next slide. Yeah, I mean, obtaining as much final information from the hospital as possible. Again, having a relationship or a contact person at the hospital when you need medical records. I'm sure you already do that. And then making sure not to include resolved conditions, as we talked about. Conditions have to be active. Next slide. Again, just reiterating, coding to the highest level. practice the assignment of the PDPM case mix to determine potential problem areas in the system. We had some great exercises with some of our clients where we actually got the documentation, went through the process of trying to pick out the diagnosis code, and we realized that the provider documentation on the diagnosis was very anemic. So that was a great exercise for them, that they knew this is one area they had to focus on to get ramped up to make sure that they're not putting the organization at risk here. Again, identify the most frequently primary diagnoses that are assigned, and then determine the value of the information provided at the time of admission, and what additional types of information would be beneficial if available. Next slide. I think these are just some resources. Again, you'll get a copy of the presentation, and Joe and I are available if you have any additional questions. Next slide. Joe, did you want to follow up with anything?
Yeah.
I think the big.
Lauren, do you have questions we can throw out, or no? They're not. Yeah. Well, so we're still processing the questions that are coming in, and what we'll do is we'll tomorrow we're going to post a copy of this webinar and be an audio recording, and feel free to share it with your colleagues. The other thing we're going to do, not necessarily tomorrow, but a few days later, we'll send you an email with answers to any questions that we receive.
Yep, and again, I think just a big driver from the presentation, making sure that the diagnoses are accurate, making sure that they're active, making sure that they're documented by the provider, and again, making sure that they are to the highest level of specificity. We can't stress those key areas enough.
Yeah, one of the best exercises we've seen, and Alicia's referenced this a few times in her presentation, is over the next week or so, get your team together and pull some records and look at how your MDS coordinator has classified the ICD-10 diagnosis, and then look at the documentation to see how well it supports it. It's a real eye-opening experience. We've been doing this with clients. It's really helped a lot. If you need our help to do it and you want some coaching on it, we'd be glad to to be engaged by you to do that. But you can do it yourself. Just pull those records together, look at the documentation, and ask those critical questions. Did we have enough specificity in the ICD-10 code, and did we have enough documentation, or did we use one of those diagnoses that were going to be kicked back to provider because they weren't specific enough?
Right.
Okay. Well, thanks everyone for participating, and we look forward to any feedback you have. You have our contact information, and we'll be again sending you a link to the recording, and also later on some questions and answers. Thanks very much.
Great. Thank you.